All right, we're going live. We are live. We've got my new assistant, Maddie, here, who's replacing Pedro tonight, and this is her first Instagram live with me tonight, so if there's any technical problems, you can blame her. I'm just kidding. So tonight, we're going to talk about the chin and jaw, but I just wanted to mention that a number of people, hey, Lil Whiner, how are you? Hey, Pedro, there he is. We're going to wave to that guy, but he's usually here with me. So a lot of people have been asking, hey, can I train with you? Hey, can you mentor me? Hey, how do I, train with you? Where do I learn all this stuff? Go back to the very first page of our Instagram and click on the link tree, that link in our bio. It has all the course schedules, how to get in touch with us, where we're located, like every information. Hey, Lil Whiner, thanks for joining. Pedro, I got three arms from him, like nice. Strong man. Thanks, Pedro. So go there and you'll see that in fact there is going to be a chin and jaw class at our Massachusetts location in Waltham, Massachusetts, just outside of Boston on December 15th. So if you want to see us there and train with us in person, please do. But go to that link in our bio. You will see like a huge program just unroll for you. And we have people waiting to answer your calls. You can email us, and we're more than happy to mentor you, get you started. If you're from outside of Massachusetts, the best place to go is Connecticut. And the reason we chose Connecticut is because if you're in Connecticut, you can get a temporary license and you can actually inject patients there. Where in most states you can't, like in Massachusetts, you have to have a Massachusetts license and be here. Best surgeon ever, that must be me, thank you. Didn't you win some Botox contest recently? Yes, thank you. So going to Connecticut allows you to actually stay there all day and inject. That's why we chose it. It's really easy to get a temporary license there, and you can spend the whole day or the whole week injecting. In fact, we have a special situation in Connecticut where you can come Saturday, Sunday, and Monday and spend 3 days with us. We'll put you up at a nice hotel and give you a free dinner. Yes, Jay Flynn, she won free Botox for a year from us. And she says, do I need to get Botox every 3 weeks? We're like, no. You're welcome. Our pleasure. It's a lot of fun. But so if you go to Connecticut, you can go all day. Particularly if you're just getting started, you could do introduction to neurotoxins all day Saturday. You've reviewed the didactic that's online. You come in and get a review, and you inject all day Saturday. Then Sunday, introduction to dermal fillers, where again, same thing. You go online, do the didactic, pass that. I'm totally winning in life. Yeah, well, you can thank us on our team. We appreciate it. We're here to help. Hey, Julie Kamen just joined. I think I know you. Austin Inbo joins every single week right at the same time. It's like 7:05. He always joins. He must have like an automatic thing. So Saturday is introduction to neurotoxin. Sunday, intro to dermal fillers, and then Monday, the biggest day of all is our cadaver dissection. I'm there personally teaching that, along with Dr. Moret, who's doing most of the dissecting, and we have like the most amazing feedback from that course. So it's a really compact 3 days, but you get your hands so wet with neurotoxin and fillers, and then you can actually do some cadaver dissection and cadaver injections, and we do the tear trough, we do the retrobulbar injections in case you accidentally blind someone. I mean, hopefully you never will, but at least you'll know what to do. Grace Kamen joined this. She's never joined before. Hey, Grace, how are you? We got to wave back. Yeah. You wave back. All right, so why are we talking about neurotoxins, fillers, when it's regarding the jaw and the chin? Well, it's trending. Everyone's talking about it. People are asking about it, and we have a course in Waltham, Massachusetts, which is just outside of Boston, on December 15th. We will be there live teaching it. So if anyone wants to join, come on over, and we'll be happy to teach. Ben Kamen, we've got the whole Kamen posse here with us tonight.
Must be the new producer.
Must be, yeah. The new producer is here. Maddie, can you want to stick your face in so they can see you?
Oh, I don't look too hot right now, but hi, everyone.
There you go. There she is. So, chin and jaw, really important. So think about it this way. When you're building a house, what's the most important part of building the house? It's the structural part, right? You have to have a good foundation. You have to have it framed out well. You have to have a roof. You have to have walls. And that's the structural part of the house. And that's what really holds the house up. If you want to put paint and wallpaper and mirrors and windows, great. It makes the house look better. But that's not holding the house up. So that's kind of what this is like. So in my mind, the structural components of the face, our house, right? The house that sits on our shoulders, is the jaw, the chin, and the cheek. Those are the three things that you have to get right. Those are the three things that provide the structure for the face. And everything else, if you want to talk about lips and tear troughs and temples and nasolabial folds and marionette lines, icing on the cake, curtains, draperies, that's what that is. But that's why we want to talk about the chin and the jaw. If you get the chin, the jaw, and the cheek right, you're 90% of the way there, and the rest you can almost not do wrong, except making the lips too big, which is one of my just pet peeves. Anyway, let's keep going. So once we understand that these are the structural components of the house, then we have to understand, okay, how do we assess them? How do we know what to do? How do we know how big you make your cheeks? How big you make your jawline? How big you make your cheek, your chin? So this is what I propose. Remember, the face is broken up into two sort of vertical planes and a horizontal plane. One is vertically, it's equal fifths. And if you take the intercanthal distance right here, measure that, that should equal the width of your eye. And that should equal the distance from your eye to your ear. So there's 3 equal fifths, right? So I would recommend starting with the cheek, as I mentioned, and do that. If you start doing your equal fifths and you find out, I'm actually a little short here because my cheeks don't come out quite far enough, then you have to start at the cheek. You have to get that right. This intercanthal distance has to equal this distance, which has to equal this distance. And if it's off, that's easy. It's like, okay, I know where to start. So let's get your cheeks right, okay? Okay, where do you go from there? Then you go down to the jaw. Why? Because the bimalar distance, let's say a woman, has to be greater than the bigonial distance, the distance between the two parts of the jaw. So there has to be, in a woman, it can be a little bit straight, but it really ideally should be triangular. So this distance, which you just fixed, has to be bigger than this distance. Okay? So if you start measuring and go, look, I'm a little short here in this woman, then you have to do something to that area. Presumably add volume. And we'll talk about that in a minute. So in a man, it's different. In a man, you have to at least be square, if not a little bit like this. I think that's trapezoidal, right? It's kind of wider at the base. So a man, the bigger the jawline, the more masculine they appear. In a woman, it's kind of the opposite. You don't really want, maybe Angelina Jolie is someone, who's a little bit different, but she's got masseter hypertrophy, so that doesn't really count, and you can treat that, and that's one of the things we'll talk about when we actually get to the treatment section. So the bimalar distance has to be greater than the bigonial distance in a woman, or at least equal. So if you start drawing those lines, you say, gee, it's kind of flat here, or gee, it's actually a little bit out like this, or it's too triangular, it's too wide, then you've got to do something to add some volume here. So let's say you get the cheek right, and you get the jaw right, and you got maybe a nicely triangular face, and you're really happy with that. Then you have to look at the chin. How do we assess the chin? Well, lots of different ways. Number one, there's 3 things we have to look for. One is the vertical height, one is the width, and one is the projection, right? 3 separate measurements. So let's talk about the horizontal dimensions first of all. So equal thirds, right, in the face. 1/3, 1/3, 1/3. So if you come down to your bottom third and you're kind of a little short here, then you've got to add to the chin. You got to make it longer this way, vertically. So you do that. How wide should your chin be? Well, it depends if you're a man or a woman. You can ask questions, by the way, and Maddie's writing questions down. If you guys come up with something, she'll just hand it to me and I'll answer you. How wide should a woman's chin be? The same as a man? No. Go back to the intercanthal distance. This distance should equal the width of the chin in a woman. In a man, it should be the corner of the mouth. So a man's chin is always sort of wider and squarer than a woman because it's much wider to begin with, so it can be square. But in a woman, it has to be a little smaller and pointed, right? So we've got the vertical height, we've got the width. And then from the side, we have to drop a line from the base of our nose to our chin. If that line's straight, we're good. If it goes backwards a little bit like that, we're retrognathic. And if it goes forward like a Jay Leno chin, we're prognathic, right? So we have to figure out what we're dealing with. So as you know, or hopefully you know by now, most of being a good injector is about being a good assessor, right? If you can't do a good assessment, if you can't find out what's wrong, how can you fix it? If you open up the hood of your car and you don't know what's wrong, how can you fix it? If you look at someone's face and don't understand the proportions and don't understand wrong is a relative term, out of proportion or this doesn't make sense, then how can you fix it? So these are simple, easy ways. Remember, start with the cheek, right? Just do the equal fifths and make sure you get the width right. Then make sure you get the bimalar distance and the bigonial distance are either the same, or the bimalar distance is wider in a woman, or the bigonial distance is wider in a man. That's kind of the first thing. Then let's talk about the chin. What do we do if our chin's too short? Well, we can certainly, non-surgically, let's talk about that. We can certainly add volume to the chin to kind of lengthen it, so again, we get that equal proportion. In the width view, the same thing. We can see if the woman's chin is too wide or too narrow. We can change that with fillers, can't we? We can make it look more narrow, or we can make it look more wide. And the lateral projection, the same thing. If it's too retrognathic, we can certainly add something. If it's prognathic, if it sticks out too far, it's hard. We can put some product, up here to change the light reflex so the chin looks smaller, but we're not really actually making it smaller. So that's the toughest one. So those are the three things. Start with the cheek, work down to the chin and to the jaw, and then do the chin. And if you get all three of those right, right meaning in proportion to each other and makes the person look better, then you can deal with what I consider those other sort of minor accessories. Go back to the temple, go back to the lips, go back to the nasolabial fold, go back to the jaw, go back to the marionette lines, all that sort of stuff. That's fine. But that will never, even if you get all those other things right, if you get the chin wrong and the cheek wrong and or the jaw wrong, it's just not going to look right. Thank you, Kate. I see people starting to do Ultra Plus for the chin. What are your thoughts? I'm not going to bash any products. That's just not what I do. But Ultra Plus is a good product. It's been around for a long time. It's very hydrophilic, right? It's not tightly crossing. It has a pretty high G prime, so it can lift. But I think the two drawbacks for me is that it doesn't last that long, and it's pretty hydrophilic. And it's one of the older hyalocross technology products. It's good. We still use it. It's wonderful. But products only matter when you put the wrong product in the wrong place, right? And Ultra Plus can be used for some of these corrections, but I'll talk to you in a second about where we're going to put the product. In my mind, if you're putting a product on bone, it needs to be a long-lasting product with a high G prime, because that's giving you all your lifting. If you're then looking at a second layer, like with my, when I do my cheek with my double layer treatment, I call it my layer cake 2, then you can put a different product on top of it. So I think there's a use for all products. The chin is a high risk. So what do you think about lateral technique? I'll talk about technique in a minute. I'm going to talk about the blood supply, but right now I'm just talking about like proportions and measurements. But that's an excellent question. I think technique matters, but what matters most is anatomy. Like, you can teach someone like whatever technique you want to teach them, but if they don't know where the anatomy is, if they don't know where the vessels are, if they don't know where the danger zones are, they're going to get into trouble. So if you ask me right now, Dr. Russo, what is the most dangerous place to inject on the face? My answer is always the same. It's the area where you don't know the anatomy. That's the most dangerous place, and it's the place where you should never be. So you need to come to our cadaver class or someone's cadaver class and really learn it, because in a book or a paper, you're looking at a two-dimensional representation. That's the average of the last 50 dissections that were done. Whereas when you're looking at a cadaver, you suddenly, the dime usually drops, or the penny usually drops, because you're looking at something in 3 dimensions. You're seeing what's deep, what's superficial, and that's really what you need to do. That's really where you need to understand it. So we talked about all those. I'm just looking at my notes for a second. Okay. So let's go back a little bit about those proportions, starting with the cheek, starting with then going down to the jawline and then the chin. What do we do if we're off, right? What technique should we use to treat patients? The main thing I want you to know is the bone is your friend. If you're on the bone, you're in a friendly place because there's no blood supply directly in that pre-periosteal space, but almost everywhere in the body, right? We've done a lot of dissections to prove that. So the pre-periosteal space is a good space, it's a safe space, but it's also an important space in these three areas because then we're talking about structure, right? So if you want something structural, it's got to be placed on a good foundation. And if you're building off a bone, you're going to get a lot of bang for your buck, right? So if I put a drop of product there, there's only one way that product can go, this way, because I'm on bone. If I'm putting product here, it's like putting a product. It's like trying to build a house on beach sand. There's nothing to support it, and it's going to kind of cave in. Whereas if I build a house on cement, I know I'm going to get a structure. That's kind of how we take advantage of the bone in both the cheek, the chin, and jawline. All three of those areas, we're using bone to help us, okay? So let's talk about, since we already talked about cheek, for millions of years, let's talk a little bit about the jawline. What is dangerous about the jawline? How do we do it? Well, I like it because it's kind of a free... There's no free zones, but it's a kind of it's safer place than some of the other areas. As you get toward the central part of the face, this sort of triangular area, that's what I call the triangle of death or the triangle of danger because that's where, so many blood vessels are located and that's where you get blindness and a lot of occlusions and hematomas, all kinds of complications, bruising, etc. But out here in the jawline, there's only a couple of blood vessels you need to know, and the most important one is the facial artery, which supplies blood flow to the entire face. How do you find it? How do you know where it is? Oh, by the way, when you guys sign in or, come on, could you just tell me where you're located? Because we've been getting people from all over the world, and it's just really fun and interesting. We have a little map and we're tagging where people are coming from, we're calling from. So we had someone from Scotland, last week Brazil, California, Canada, the Canary Islands 1 week. It was kind of crazy. And England, a couple from England. So just tell us where you're from, what you do, whether you're an RN, NP, MD. It's always interesting to know who you're talking to. Los Angeles, see right there?
Nice.
Very cool. Very cool. Thank you, Viviana. Utah. All the western states, it's still early for them. Massachusetts, Christine. I keep losing my train of thought. Oh, yeah. So here we have the superficial temporal artery, right, going up this way. So it's kind of in the posterior aspect of the mandible. But the facial artery is the one you should worry about. How do you know where it is? Soon to be an RN now, soon to be an NP. All the power to you. Connecticut NP, Bridgeport, El Paso.
New Mexico.
Awesome. Brunswick, Maine. So bite down hard, and right at the anterior border of your masseter, right there. If you palpate it lightly, you'll feel the facial artery. That's giving you blood supply to your entire face, right? That's a branch of the external carotid artery, and you don't want to mess with it. So sometimes, particularly when I'm teaching injectors, I say, feel it, palpate it. Just put an X over it so you know when you're injecting really never to go near there. Orlando, Florida. I'll be in Tampa this weekend visiting my kids, looking for some warm weather rather than what's up here in Boston. Your own med spa called Revive. Yeah, okay, excellent. Very happy for you. We should talk later. So mark that because you don't want to be near the facial artery. And then there's a posterior branch, the superficial branch of the temporal artery that comes up and gives the occipital and parietal branches. But you're not going to really be back here. So when you're injecting, I like to start by putting a bolus on the bone, right, at the angle of the mandible right there. And I consider it kind of a free space. I usually put 0.2, 0.3 cc's there. And then I like to fan. Now, what shape am I looking for? Well, in a man, I'm looking for a right angle. The ramus in a man is long, and you have sort of a straight right angle. In a woman, the ramus is kind of short, and you have sort of a more, like this is a man, this is a woman. A woman has more of an open angle. Their jaws are kind of like this. A man is more like straight across, and this part is long. So, when you're doing a man versus a woman, make sure you understand what the differences are, right? Make sure you understand the difference in shape, right? The bigonial versus the bimalar distance. Make sure you understand that, in a woman, you probably don't really want this kind of trapezoidal face, or even sort of a straight, even face. You want this to be smaller than this, so you have a triangular shape. So sometimes when we run across people who have that masseter hypertrophy, neurotoxin works extremely well there. It's a real face shaper and a real face sort of narrower in women. I mean, you would never do that in a man, because the bigger the man's masseter, the more masculine they look, the more meat they eat. So we want sort of a square jaw in a man, and sort of more open, maybe 110, 120 degree angle in a woman. And it's all about the length of this rim here, right? Of the ramus of the mandible. So factor that into your thinking when you're doing it. But I think the two safe places to be are on the bone. You're not going to have any trouble. There's no real big vessels at all here. So it's really quite a nice area. And then in that either intradermal or superficial subcutaneous space, you can do your retrograde fanning and get a very nice result. I like to use something with a high G prime there. I want something that's really going to lift and give me some good definition. And you can even kind of go along the jawline, but remember, stay away from the facial artery. That's critically important, because if you mess with that, again, the whole blood supply of the face is kind of depending on that. So not a good thing to do. So what about the chin? Well, we just did a recent cadaver dissection in our last class a few weeks ago, and guess what we found in this one patient with this one cadaver? When the facial artery came up and bifurcated and gave rise to the inferior and superior labial arteries, the inferior labial artery was there, but really not at all impressive and kind of hard to find. But there was a mental artery that was so big and went directly into the lower lip that you have to really consider that, because it comes out right there in the mental foramen, right? And it goes up this way toward the mouth. So, and there's also a submental artery, which is right next to it, that comes out from in the neck area. We have seen a couple of occlusions in that area, probably from the mental artery. We've seen some loss of lip stuff. So the two places to be safe are on the bone, but remember, you always have to aspirate when you're through the dermis. What was the best product for the lower face? It depends. I use every product in the lower face. It just depends what you're doing. Nasolabial folds versus marionette lines versus on the bone versus something superficial. So I need a more specific question to answer that, because we use all the products in the lower face. So the cadaver class was the best class? Thank you. Yeah, I take personal pride in that class. I really put a lot into it, and I learn something every time I teach it. But anyway, back to where we were. So the mental arteries and the submental arteries are ones that people don't talk about a lot, but you also have to consider the inferior labial artery, because it can actually come and sort of droop down this way and kind of come right across where you're going. So we've seen it actually as low as the mental crease. So the bone's your friend. The subcutaneous space is a little bit not so much your friend. The intradermal space is your friend as well. So you've either got to be really deep on the bone, but again, because these arteries are running deep here, always aspirate. And when you're up here, be pretty superficial, right? You don't really want to go above the mental crease, because then you're inside the mouth, and people can, will feel the product inside the mouth. So you never really want to inject above the mental crease unless you're really in that superficial plane. But you don't usually need to be there. So remember that. Most of the injections are on the bone, and if you're on this part of the bone, you're pretty safe. Always aspirate, and then you can go to the superficial plane if you need to. But honestly, most of the time in the chin, you don't need to be anywhere but on the bone. At least that's my opinion. Particularly in someone who doesn't have a lot of volume loss, but you're just trying to get those proportions right. Just to repeat, start with the cheek, right? Intercanthal distance should be the same distance as the eye, and the same distance as from the edge of your eye to the corner, to the end of your cheek. If you find you're deficient, fix the cheek, compare that to the jawline. Your bimalar distance should be bigger than your bigonal distance in a woman, opposite in a man. And then the chin, you've got the 3 dimensions to measure the width, the height, and the projection. Remember, this is equal thirds, and this is equal halves, from here to here, and here to here. So just some things to measure. Remember, the upper lip in a Caucasian is about 40 to 60, upper lip to lower lip. Just something to remember, because these are all good guidelines to help you with proportions. Once you get those proportions right, you can do the more... Are you going to retake the cadaver class? Yeah, I think everyone should take more than one cadaver class. You learn... Honestly, the more you know, the more you learn from a cadaver class, because the more sort of questions you have about it. And one of the other things that really helps you understand, like particularly in this area of the chin, this is another thing we should talk about with the chin. One of the most common complications when people are doing neurotoxin, people take neurotoxin for granted. Julie Kamen, do you say when you're doing the live demos? Oh no, I didn't. I forgot about that. Do we actually have a date for that? One of our Instagram lives, is it 2 weeks from now? We're going to do a live demonstration. So a lot of these things I'm talking about, as I was saying, you can only teach someone so much when you're talking to them or showing them a book. We're actually thinking of doing Instagram live in my office, but we're probably going to have it like around 5 o'clock because everyone wants to go home after that. So we'll do something like this. And when I asked people about it last week, December 7th. Okay, December 7th, our Instagram live is going to be me doing live injections of a local radio personality who loves to talk. But she's not going to be allowed to talk much because I'm going to be injecting her face. So it's going to be really exciting for me. So we're going to set up just like this, but I'm going to say, okay, this is how I do the jawline. This is how I do the cheek. This is how I do the chin. People can ask me questions, and I'll do it. So it will be me doing the injections, and I'll take questions from the audience, or someone says, hey, how do you do this or that? We'll do it. I'm not going to spend all night doing it, obviously. I want to, keep something for the following weeks. But I think it was well received. When I asked the questions, people responded. Is that something you guys would be interested in? If you are, just say yes, and so I know that it's worth doing. Getting a bunch of yeses. Okay, all right. So we'll do it December 7th, which isn't that far away. I guess it's like 2 weeks. Okay, 2 weeks. And then in Waltham on December 15th, we're having our chin and jaw class. So everything I'm talking about tonight will be there, and you can actually inject patients. Yes. You'll be able to inject patients with the chin and jaw techniques that we talked about, and a lot of them we've invented. So one of the big issues I've seen here is people underestimate how difficult neurotoxin anatomy is. And I see even, tell me where you guys are from. It's always interesting to hear where you guys are from. Kate, I'm sure you would always say yes. People underestimate how important it is to know the anatomy, and even advanced injectors for prognathism, bigger lips for better proportions. Yeah, I mean, if the chin's too big, you make the lips bigger, it makes the chin look smaller, and vice versa. If you have small lips, it makes the chin look bigger. So if you want to make the lips bigger, that does help the chin look smaller. Very good point. So the overplay between the masseter muscle, the DAO, the DLI, and the mentalis, they're all right together like this. And until you actually see a cadaver and you pull the skin away and you see how closely interdigitated those are, you see why so often people have a DLI problem. So they smile and one side goes like this, one side goes like this. This is the side that's working. They knocked out this DLI, and it doesn't depress when they smile, because when you smile, you're supposed to see the person's lower teeth. And if you knock it out, it doesn't depress. Everyone thinks this is the side that's bad, but it's the opposite. It's kind of crazy. And the reason is they don't understand how close these all are. So when you see how on top of them each of them are, you understand that there's a certain place where you can inject the masseter, there's a certain place where you can inject the DAO and the mentalis, and how you have to avoid the DLI, because it's a terrible thing to have someone with a really asymmetric smile. Took the courses in 2018. Oh my God, we're on steroids now. That course was like a training wheels course. These courses now are like on steroids, and we're mostly on demand. Then you come in and do your hands-on with us. Go to the link in our bio, and you'll see there's a whole link tree thing that will show you all of our courses, our locations, where we teach, how to get a hold of us, what days our courses are taught, in which city. We'd love to have you join us, and I always get questions about, will you mentor me? Will you show me how to do this? And this is your chance to do it. So hopefully you understood all about proportions, understanding proportions, getting the chin, the cheek, and the jaw right, because those are your structural components of your face. And if you get those right, everything else is easy. If you get those wrong, nothing else looks right. So you got to start there. Remember the proportions I told you. As far as neurotoxins go, we talked about the masseter. The masseter, at one point I want to make about the masseter. People who have like such masseter hypertrophy that it feels like they have a walnut there, they struggle. They have pain, they have headaches, their teeth are grinding. And injecting that masseter when it's hypertrophied is a godsend for people. I just saw a woman today that I did it. She's like, this is like the best thing I ever did. I was doing it to kind of slim her face a little bit, but she's like, she said, I knew my Botox was wearing off when I got my first headache in 3 months, and she was right. So she came in today and got some more. But the thing you need to know about the masseter is there's two heads to the masseter, and if you just inject deep or just inject superficial and the deep head's still going, you can get still get a bulge there. People are like, well, how can I still get a bulge there? I injected right into the masseter. Well, you have to inject deep and superficial, and you should never go above the bone, because if you do, you got the risorius, you've got a couple other muscles that are the buccinator that are right next to you, right below the masseter. So if you go too deep, too high, you're going to hit them, and the person's not going to be able to smile properly or move their mouth properly. So again, these are all things you learn in a cadaver class. So I think I covered the neurotoxin part. Oh yeah. So the other thing I just want to mention in general, energy-based treatment. So whenever you do these treatments and you're making people look better, get some energy-based treatments. Get something that does radio frequency or microneedling with radio frequency, ultrasound, laser, something, because you want to make these results last and maybe enhance them. And then once you get these 3 structural areas, right? Look at the temples, look at the tear troughs, but don't touch them because you'll get into trouble if you do. The lips, the nasolabial folds, and marionette lines, much easier areas to treat because they're not structural. They're more like sort of cosmetic regions. But get the bony stuff right first, and then you'll be able to go from there. Maddie's writing down some questions for me that you guys, neurotoxins for bruxism taken care of with risorius. Yes, hold on a second. Let me get that. First question.
These 2 have been answered. So these
okay. The chin is a high-risk zone. What do you think about the lateral technique? Yeah, I kind of answered that. I'm not so sure the technique matters as much as it does an understanding of the anatomy. Understanding where the facial artery branches, understanding the submental and the mental arteries, and understanding that the bone is your friend are the main concepts I want to get across. The lateral technique, coming in lateral like this, is fine. I'm personally the kind of guy that likes to go directly onto bone in bolus. I don't like kind of coming across on the bone. I think it kind of defeats the purpose of being on the bone. I want to be on the bone because I want to bolus. I want to be on the bone because I want to get the maximum effect from the minimum amount of product. I want to do with 1 cc what it takes you 3 cc's to do. So I want to show you that I'm 3 times better than you. I'm just joking, but my point is that the best injectors get great results with very little product because they understand how to maximize the results. And I think going directly down onto the bone and bolusing, using a Hershey kiss technique or the snowman technique that Swift talks about, it doesn't matter, but you want to build on bone so you can pull out like that. So that was my answer to that. What would you say is the best product for jawline filler? I personally like to use Voluma. I think anything with a high G prime, Restylane Lift. There's going to be a new product coming out called Lift, which is even, from Allergan, which is even more tightly crossing. It has more HA than even Voluma, and it's going to be meant for jawline definition. I'm anxious to see that. I think it's going to be early 22. But yeah, I'm a Voluma guy. I like it. I think anything that you can use with a high G prime that isn't particularly hydrophilic is going to be your choice, because you really want something firm, hard with definition that's going to lift and give you bulk. Because when you're out here and you're adding volume, look what happens to the marionette line. Right? You pull back, you start filling these areas. It really is important. So you need something with a lot of lift to it that's going to give you the oomph that you need. Recommended bolus amounts per injection for chin jawline. Rarely do I go over 0.3. I don't think you need to. 0.2, 0.3 is my... I think 0.1 is too little. I think more than 0.3 is too much. So I'm usually at 0.2, 0.3. And I just, to be perfectly honest with you, I don't actually look at the syringe when I'm injecting. I'm looking at the tissue, looking at where I'm going. As I'm injecting, I'm seeing what's happening with the tissue. And when I feel that I've got enough of a tissue response, I stop and then I look at the syringe. But it's usually about the same. Sometimes I will look if I'm concerned I'm putting in too much. Hi, Wendy Diamond. It's been so long. How are you? Good to hear from you. Do you feel doing RF with microneedling or Ulthera and laser first to build up the integrity of the skin, then do your injectables? I'm the opposite guy. I like to get the structure right first. I think the things that you're talking about are good, but I think they're more like superficial. Again, structure is all about structural support. Cheeks, chin, jaw. Those are like the foundation, the walls of your house, the roof of your house. And, that's what's really going to support the whole structure. Then doing things to the skin and the areas where there's volume loss are great. But, you don't want to put the windows in and the rugs in and the wallpaper and the paint in before you finish the structural part. So do the structure first and then enhance and maintain that with all the things you're talking about. That's the way I've always done it, and that's the things that's I think it's made me successful over the years. There's really no right and wrong, but I just like if I think about it structurally, I think about I'm not going to even talk about buying windows and wallpaper until I have the foundation, the walls, the roof, and the framing done. That's just kind of how I look at the world. And these are the structural components that I'm talking about. Hi, Victoria. I know who you are.
Me too.
She works at our front desk.
The only one you haven't answered is this.
Neurotoxin for bruxism and taking care with psoriasis. Yeah, bruxism and sort of clenching and hypertrophy of the masseter are a very serious problem. If you go too deep with your masseter injections, you can hit the buccal needle or the psoriasis, which connect to the corner of the mouth. So you got to really stay low. Make sure you're over the bony part, the lower half of it, and make sure that you do injections. I usually do 3 or 4 injections. The minimum I did one today, was I only did 15 units, but normally I'm doing somewhere between 20 and 30 units per masseter, right, per side. So I kind of start deep and kind of come more superficial, so I get both the deep and the superficial heads of the masseter. It's hard to overtreat a masseter, right? If a patient asks, will it break my volume down? No. The areas you're treating with microneedling and heat, topical heat, are not going to affect deeper. If you've injected Voluma on the bone or anywhere else, there's no way you're going to put enough heat into it to do any damage to it. Honestly, don't worry about it. And any topical treatment that you're talking about, you can't get the skin hot enough, long enough, because no one can tolerate it. Once you get someone up close to 40, 38, 40, 41, 42 degrees, they tell you to stop because it hurts too much. So you're getting there just quickly and for a very short period of time. You're not getting any deep heating. Believe me, I know how much heat it takes to get deep. I do a lot of treatments with body tight, face tight, AccuTight, and I know I have my thing set at like 68, 70 degrees centigrade, 140 degrees. It still takes quite a few minutes to get that tissue, because it's such a sink for heat. It can absorb so much heat before you damage it that I have no concerns about damaging neurotoxin or filler, certainly filler, with any kind of the topical treatments that you mentioned. So don't be afraid to do it. I'll tell people wait a week, let it get in, integrate it into the tissue, let the neurotoxin get into the muscle. Then you can do whatever you want. I put no restrictions on it. Excuse me, and I've never seen a problem with it.
That's all we have so far.
That's all we have so far. Well, that was great. Any last minute questions, send them over right now. It was great to see all of you tonight. This was really a lot of fun. So remember, 2 things. Check the link in our bio. You'll see all of our classes, all of our schools, whole curriculum, which ones I'm teaching, which ones are online, which ones you have to come in for. December 15th, we're doing our chin and jaw class. So if you like this meeting or this Instagram Live, come to our class in Waltham on December 15th. And or on December 7th, I think our Instagram Live is going to be me doing live injections, right, to show you my technique, some of the techniques I've invented. I'll talk about why I do it the way I do it. I'll show you. Happy Thanksgiving to everyone. Yes, you beat me to it, Wendy Diamond. I want to talk about, when I'm injecting, what am I thinking about? Which vessels am I thinking about? What depth am I thinking about? Remember, deep is safe, superficial is safe. That in-between layer is where you got to stay away from. So, but I'll do that, and everyone seems to be. Our next cadaver class is, I believe, in January in Connecticut. I'm not 100% sure, but go to our link in our bio. It'll tell you exactly. I honestly don't know, but we do one every couple months. We split them in Connecticut and in Massachusetts. If you are an out-of-state person and want to come train with us, you ought to go to Connecticut, because in Connecticut, it's a really interesting state. They let you get a temporary license, so when you're actually here, you can inject patients that are here. And that's really the strength of our program, is we let people inject multiple people during their neurotoxin and filler courses and their practice sessions. We have over 3,000 people on our model list, called the Model app, and they're always available for people to inject. If you're in Massachusetts or some of the other states, and you're not a Massachusetts resident, you can't inject someone from Massachusetts. So that's why we went to Connecticut, so we can start teaching out-of-state students. So a big shout out to Dr. Russo and Dr. Murray. Yes, thank you. See, thank you. Carmel, are you just joining at 7:40 when we've been on for 40 minutes? Are you seriously telling me you're just getting on now? I cannot believe that. Thank you for joining anyway. Anyway, it's been a pleasure. Happy Thanksgiving, everyone. Really enjoy your meal. Travel safely. Be well, and I'll see you next week.